Good evening, everyone. This is NU 121 EPU pre-conference video for week 4. I am one of your fill-in instructors. My name is Lindsay Porter. I have my Master's of Science in Nursing. I'm a family nurse practitioner, board certified. We're going to review the start of your cardiac concepts that you may see in clinical. Please bear with me. You have a lot of pharmacology as well, so I want to break that into a different section. So first we're going to talk about common disease processes that you may see in the hospital. You might have already encountered some of these as well, but this is super important. These are concepts that you're going to be constantly revisiting, whether it's a patient's admitting diagnosis, their main diagnosis, or if it's in their health history. Okay, hypertension, pretty common in the hospital. The definition is persistently elevated blood pressure that's greater than or equal to 130/80. Risk factors, stroke, heart attack, and kidney. And then management is going to be lifestyle changes, taking their antihypertensives and being compliant with them. A lot of times some patients, they can't afford their medication, or maybe they don't have transportation to pick up their medication. So medication adherence is super big with this, because patients can go into a hypertensive crisis and have to be admitted to the hospital for blood pressure control. So this is super important. Okay, next up we have angina. This is caused by, this is chest pain from myocardial ischemia, whether it's in the coronary artery supply or somewhere else on the heart. There are different types. So stable is predictable, or it can happen due to overexerting yourself. And then unstable is unpredictable and emergent. So treatment is typically nitroglycerin. Please make sure you know side effects of nitroglycerin, you know medication adherence, safety for when you're also administering the medication for yourself and the patient, and knowing when to hold it. That's extremely important. Nitroglycerin, you're going to see that a lot on your NCLEX and probably practice questions. Beta blockers, again, knowing your nursing interventions and considerations for that medication, and then also obviously lifestyle modification. Arterial insufficiency is the narrowing or blocking of arteries, usually from atherosclerosis. So you guys probably learned about atherosclerosis last semester. So now you're kind of taking, okay, they are now past atherosclerosis. They now are having narrowing and blocking of the arteries. And so now your patient might actually have some symptoms. So symptoms could be cold, pale extremities, pain with activity, also known as intermittent claudication, and ulcers on the toes. Treatment for this is smoking cessation, exercise, medications, and surgical revascularization. So a lot of you have probably heard of a fem popliteal bypass. This would be a surgery that would be consistent with someone who has arterial disease in their legs. Also, too, you want to make sure that you are grading your pulses. If you're unsure, you're like, I don't know if I can really feel for a pulse, you want to grab probably a portable Doppler. They typically are on the floors, and some ultrasound gel, just to make sure that you're getting accurate pulses, and if you're not getting accurate pulses, to make the surgeon and doctor aware. Okay, venous insufficiency. So this is the opposite of arterial insufficiency. So you have valve failure in the veins, which leads to blood pooling. So that's where patients will get that skin discoloration. It's actually from the blood pooling in their legs. Symptoms, you'll see edema, varicose veins, skin discoloration, ulcers near the ankles. Also, too, you do want to assess for sensation, temperature of the extremity, and also Dopplering those pulses if you're having a hard time palpating the pulses in the lower extremity. Treatment, again, would be compression stockings, leg elevation, and surgery if severe. Deep vein thrombosis, also known as a DVT. This is a blood clot in a deep vein, usually in the legs. Signs would be swelling, redness, pain, warmth. Risks, it can dislodge and lead to a pulmonary embolism, also known as a PE. Typical treatment for this is anticoagulants, so knowing heparin and warfarin. Please know the anecdote for these medications. So for heparin, it's going to be protamine sulfate, and for warfarin, it's going to be vitamin K. Also know thrombolytics as well. So anticoagulants and thrombolytics are not the same type of medication. They do thin the blood, but they have different they target different aspects of the clotting cascade, so it's really important that you guys know the difference of those. Okay, heart failure, it's the definition, it's the inability of the heart to be able to pump blood effectively. So think of a failed cardiac pump. There's two types, left-sided, which is the pulmonary symptoms, and then right-sided will be, like I said, more systemic symptoms, or you can actually have both. A big thing that you'll want to get off of an echo from heart failure to try to see how much reserve a patient has is going to be called the ejection fraction, and that is found on the echo report. So make yourself familiar with that. You also want to make yourself familiar with the BNP level. Again, that's BNP level. That is an enzyme that leaks in response to cardiac damage. So symptoms would be dyspnea, fatigue, edema, weight gain. Management, again, diuretics, ACE inhibitors, beta blockers, and lifestyle changes. So a lot of crossover treatment with medications for hypertension and heart failure. Pulmonary edema, this is fluid accumulation in alveoli, usually due to a patient having heart failure. So your patient may complain of severe dyspnea, pink frothy sputum, and crackles. That's a pretty textbook example, as I like to say. Treatment would be diuretics, oxygen. You're going to treat the underlying cause, which is usually heart failure, like I stated. Okay, the last concept we're going to learn about is pulmonary embolism. So this is defined as blockage of a pulmonary artery by a clot, which is often from a DVT. Also to make yourself familiar with the left atrial appendage, which comes off of your left atrium. It is a big problem in patients that develop atrial fibrillation, which is a cardiac dysrhythmia that lies in your atrial chambers. Blood lies stagnant in that left atrium, and then it gets um, pulled into the left atrial appendage, which is a little pouch that extends off the left atrium, and about 90% of clots actually form there. So that's why people who have AFib are typically on blood thinners. And then once they're doing good on their blood thinners and everything's within range and everything looks good, typically they will offer them the Watchman device, which is something else you guys can look up. That is a device that can be offered to them, and then the patient can actually end up coming off of blood thinner therapy, which is really nice because it does put our patients at an increased risk to be on blood thinners, as you guys know. So symptoms, again, sudden dyspnea, chest pain, tachypnea. They may be coughing up some blood. Treatment would be anticoagulants, thrombolytics, and oxygen therapy. Okay, so I know we are done with this pre-conference, but I do like to give you guys kind of a lot of tips to remember by condition. So for hypertension, you're going to want to remember to control the patient's blood pressure, right? So early on, we should be telling them that they need to be moving their body, they need to be limiting their salt intake. And this is honestly just to help them to prevent long-term complications such as a stroke, kidney failure, and a heart attack. For angina, we want to recognize the pattern of their chest pain that they are describing. Stable angina is pretty predictable, but unstable angina can be a warning sign of a potential heart attack. So just making sure that you're differentiating between, is the chest pain stable or is it unstable? For arterial insufficiency, you're going to look for classic signs. The patient's going to have cold, pale limbs, with pain during walking, also called intermittent claudication. And you're going to want to promote circulation through lifestyle and medical interventions. So one way I remembered arterial versus venous insufficiency was the acronym DAVE. So if it's an arterial problem, you're going to dangle. So D stands for dangle, A stands for arterial, V stands for venous, and E stands for elevate. So if it's a venous problem, we're going to elevate. If it's an arterial problem, you're going to dangle the legs in the dependent position. For venous insufficiency, you'll see chronic leg swelling, skin changes below the knee, often indicating venous insufficiency. So compression therapy is key, along with elevation, as we just said. Deep vein thrombosis, so early detection is critical. Make sure you are aware of common hospital scenarios that can put your patient at an increased risk for a DVT, immobility, post-surgical, if they have any if your patient just had like a C-section, if they were recently hospitalized, if they've experienced a long bone fracture, if they've been traveling, like in a car for a really long time, or have been on a flight for a really long time. So with that, early detection is critical. Leg swelling, redness, pain. Usually it's unilateral. It could be in both, but for the most part, it's usually on one. So pain warrants prompt evaluation to prevent pulmonary embolism. For heart failure, you're going to want to focus on monitoring your patient for fluid overload, so daily weights, edema, and making sure you understand the difference between like a +2 versus a +4. Shortness of breath, and making sure you're understanding that left side of heart failure, left side goes to lungs. So your symptoms are going to be more pulmonary related, right side is going to be more systemic. For pulmonary embolism, your patient's going to complain of sudden chest pain and difficulty breathing after immobility, like I said earlier, surgery. Those scenarios should raise a little bit more suspicion for a PE, and you'll want to administer emergency care with that. Also, too, I know some of you like to study and know what kind of labs follow that. So the patient can undergo what's called a D-dimer blood test. If that's elevated, typically they'll confirm it with like a CT perfusion scan, or they also can do a VQ scan as well. For pulmonary edema, the patient's going to have frothy pink sputum that's pretty telling of what's going on. They also have crackles on auscultation when you're listening. Remember, crackles is an adventitious breath sound. So that would signal that there is fluid in the lungs. So urgent diuretic therapy is often required. And remember, with diuretics, some of them you're losing potassium, some of them you're retaining potassium, right? So make sure you understand the complications if the potassium goes too high or if it goes too low.